welcome to the tutorials in echocardiography, coming to you from Mayo Clinic in Rochester, Minnesota. I'm Dr. Grace Lynn, your host for this series. This tutorial is presented to you by Dr. Heidi Connolly, Director, Mayo Clinic, Congenital Heart Disease Center, Chair for Education, and Professor of Medicine in the Division of Cardiovascular Diseases and Internal Medicine at the Mayo Clinic in Rochester, Minnesota, and Dr. Sabrina Phillips, also a member of the Congenital Heart Disease Group, and an Assistant Professor of Medicine in the Division of Cardiovascular Diseases and Internal Medicine at Mayo Clinic in Rochester, Minnesota. Upon completion of this program, participants should be able to demonstrate the comprehensive approach to the echocardiographic assessment of the adult with unoperated and operated congenital heart disease, review the basic echocardiographic anatomy and associations of simple unoperated congenital heart defects found in adults, and recognize the echocardiographic anatomy of complex congenital cardiac lesions identified in the adult. Stay with us as we discuss this important topic during this program entitled Echocardiography in Simple Adult Congenital Heart Disease.
Thanks very much for that introduction. Today we're going to talk about a systematic approach to the echo assessment of adults with congenital heart disease. The segmental approach is very important in the echo assessment of patients with adult congenital heart disease. We want to identify the position of the heart, that's the location and orientation, also the situs, which refers to the visceral and atrial situs, and that's the spatial arrangement of the asymmetric organ systems. Segments of the heart are extremely important in delineating complex congenital heart disease, and we'll look at those. Those are sections of the cardiovascular system, and then the connections are the junction between two segments. And we'll look at each of these in great detail. The echocardiographic examination of a patient with congenital heart disease starts with the subcostal window. And in this still frame, we see the liver on the left side of your screen, and the inferior vena cava lies, of course, to the right of the aorta. In this image, it's on the left side, of course, because we're looking from the subcostal approach. So the subcostal approach helps us to identify the visceral situs, which also goes along with the atrial situs. And let's look at a real-time image which will demonstrate this quite nicely. So again, liver on the left side of your screen. We can see pulsations of the aorta, which lie in the midline. As we turn to a longitudinal plane, the inferior vena cava is demonstrated now in this longitudinal plane. We can see hepatic veins entering the inferior vena cava and start to see the right heart chamber, the right atrium come into view. As the transducer is angled medially, we see now pulsations of the abdominal aorta, and color flow demonstrates excellent pulsatility of abdominal aortic flow. The pulse wave Doppler examination of the abdominal aorta is very important and helps to determine or identify a potential obstruction, and we'll come to that shortly. Now we've moved a little bit more medially. We can see that the inferior vena cava is in view, and indeed the entire atrial septum can be viewed from a subcostal format, similar to the bicaval view that we identify by transesophageal echocardiography. So on the left side of your screen is the inferior vena cava. On the right side of the screen is the superior vena cava. Apex down format is generally used in the assessment of patients with congenital heart disease, and we'll look at all apical images in an apex down format, and that just helps us to determine the orientation of the heart. And here in a normal orientation, that's upper right to lower left, we know that this patient has levocardia and situs solitus. Additional information, of course, can be obtained from the subcostal format, but we'll look at some additional details shortly. I commented on the normal pulse wave Doppler profile of the abdominal aorta, demonstrated in the top panel, a brisk upstroke shortly after the QRS, usually a peak of about 1 meter per second, and then rapid deceleration, and early diastolic reversal is normal. Contrast that to the abnormal pulse wave Doppler examination demonstrated in the lower panel. In this panel, you can see that the antegrade velocity is low, about 0.4 meters per second. There's a delay in the upstroke and persistent flow in diastole. And indeed, this is consistent with coarctation unless otherwise demonstrated. So essentially always consistent with important obstruction in the thoracic aorta. The next thing that we want to look at is the orientation of the heart. The normal orientation, or levocardia, is an upper right to lower left orientation as demonstrated in the left panel. In the middle panel is mesocardia, upper midline and lower midline orientation, and then dextrocardia. In this situation, we have upper left to lower right orientation. And indeed, the cardiac position in the chest it does incorporate not only the base to apex axis orientation that we just looked at, but also the location of the heart in the chest. Remember that if the right lung is hypoplastic, that the heart might move into the right chest, but that's a dextro position rather than dextrocardia. So we want to look at the position of the heart in the chest, but also the base to apex orientation, and both of those are very important. Now, cardiac looping is another noteworthy and important feature that we need to just touch on. In fetal life, the heart starts as a tube, and early in the development of the heart, it goes through a process called looping. Under normal circumstances, we have a D-loop, and that refers to the morphologic right ventricle ultimately being to the right of the left ventricle. In an L-loop, however, the morphologic right ventricle with its tricuspid valve lies to the left of the left ventricle. And that will become important as we talk about some of the more complex lesions in congenital heart disease, and we'll come back to that later. Let's move now to the cardiac segments, and we're going to talk a little bit about each of these: the veins, the atria, the ventricles, and the great arteries. Now, the veins are important, pulmonary veins and systemic veins, but really by echocardiography, other than transesophageal echo and certain image formats in the transthoracic approach, they're difficult to visualize. So let's look then at the atria. How do we identify the right atrium? The right atrium receives, of course, the inferior and superior vena cava. It's characterized by pectineate muscles, which are nicely demonstrated in this pathologic example. The ridges over on the left side of the panel. The crista terminalis separates the smooth surface from the pectineate muscles and is nicely demonstrated in this specimen also. And the right atrial appendage is quite different than what we know the left atrial appendage to look like, in that it has a broad base and is demonstrated at the top part of this anatomic specimen. In contrast, the left atrium receives pulmonary veins, and it's characterized by that very unique appearance of the left atrial appendage, a narrow base with multiple frond-like structures as demonstrated in the right upper portion of this pathology image. Now, when we think about the atria, the important things from congenital heart disease standpoint are the atrial septal defects. And there are 4 important types that you'll need to remember. You'll hear much more about these later in the series. But the most common type of atrial septal defect is the secundum defect, making up about 75% of atrial septal defects. It's located in the mid portion of the septum and demonstrated in this schematic by number 2. The next most common are the primum atrial septal defects, located in the lowermost portion of the atrial septum, here in this image demonstrated by the number 1. As we're looking at the atrium here from the right side, we can see that that lies just above the tricuspid valve. The sinus venosus atrial septal defects, as demonstrated here by number 3, represent a less common form of atrial septal defect In fact, this is a superior form of sinus venosus atrial septal defect, and occasionally we'll see an inferior form of a sinus venosus atrial septal defect as well. These defects make up about 5 to 10% of the atrial septal defects. And finally, the coronary sinus atrial septal defect, or unroofed coronary sinus, very uncommon, less than 1% of cases, and that's depicted here by the number 4. We'll look at each of these in a little bit more detail, both pathology and real-time echocardiographic imaging. So this is a pathologic image opened from the right side. We're viewing the right atrium on the left side of the screen and the right ventricle on the right side of the screen. The asterisk demonstrates a large secundum atrial septal defect. You'll see that it's located in the mid portion of the atrial septum, and this is usually an isolated abnormality. Less than 5% of cases will have associated anomalous pulmonary venous connection. This is an important finding because over many years of a left to right shunt, the right heart enlarges and patients will develop symptoms and may present late in life. Generally, we'll recommend intervention if the right heart is enlarged as long as there isn't severe fixed pulmonary hypertension. And importantly, these are the only atrial septal defects for which device intervention is feasible. Looking at a real-time image here, paraapical imaging or off-axis right ventricular inflow view. The blue arrow demonstrates the right ventricle, and of course, in the far field is the right atrium. You'll note as we play these images that the right heart chambers are enlarged, that there's dropout in the region of the atrial septum, and that color flow transits from left to right in this patient with a large secundum atrial septal defect and important left to right shunt. The secundum atrial septal defect is beautifully visualized by transesophageal echo. In this still frame, left atrium is at the top of the screen and right atrium at the bottom in the 2D image and as demonstrated by signatures. Color flow demonstrates the left to right shunt that is present in these patients. And indeed, we would want to look for the unusual association of anomalous pulmonary venous connection. This is a 3-dimensional image of the atrial septal defect, and we can see how much the defect changes throughout the cardiac cycle, and really emphasizes that one measurement in one plane is not adequate to determine the size of a secundum atrial septal defect. When we think about genetic implications of congenital heart disease, the one thing that you should keep in mind with regard to the secundum atrial septal defect is that there are several familial syndromes that can be associated with these disorders. Holt-Oram is the most common. This is a heart-hand disorder. The most common associated congenital defect in the Holt-Oram syndrome is a secundum atrial septal defect. And then familial atrial septal defects may be associated with atrioventricular conduction defects. So always think to ask the family and potentially screen them as needed. Turning our attention now to the next most common atrial septal defect, the primum atrial septal defect, as demonstrated by this asterisk. We're looking here at the heart from the left side. Left atrium on the right side of the screen, left ventricle on the left side of the screen. And the other important finding that's demonstrated here is a cleft in the anterior mitral leaflet. So primum atrial septal defect and cleft mitral valve often go hand in hand. The other characteristic features that we want to look for in this type of defect is an abnormality of the tricuspid valve, because this is a defect close to the, very close to the atrioventricular valves, where the AV valves are frequently abnormal. In addition, ventricular septal defect may be present, and in that case, we would call this a transitional or partial AV septal defect. And then left ventricular outflow tract obstruction may occur later in life. One of the pearls for this type of atrial septal defect is that the electrocardiogram characteristically demonstrates left axis deviation and first-degree atrioventricular block, a common question on board examinations. And here's some real-time images, again, apex down format. The blue arrows on the left panel demonstrate the right atrium on the top and right ventricle on the bottom. And as we look at these images in real time, you'll note that the atrioventricular valves are at the same level and that there is a large defect in the lower portion of the atrial septum, a primum atrial septal defect. With color flow examination, we can see flow through that primum atrial septal defect and then tricuspid regurgitation, as well as some mitral valve regurgitation in this particular patient. Other associated defects with this primum defect or partial atrioventricular septal defect are important. We've already alluded to the cleft mitral valve, as is demonstrated in these short axis images. The image on the left with the arrow demonstrates a large cleft, and as we look at that in real time, we can see that, of course, there would be important mitral valve regurgitation associated with this cleft. Always important to look for it and very important to close at the time of operation. The image on the right just demonstrates a measurement of the cleft size, which is close to 1 centimeter. And here we have an image of another associated abnormality, and that is double orifice mitral valve, and this can also be seen in patients with partial atrioventricular septal defects or primum atrial septal defects. So nice example. You could see the two orifices of the mitral valve very nicely. What about genetic implications? These defects are very common in individuals with Down syndrome. Down's patients have a very high frequency of congenital heart disease. Over 40% of patients with Down syndrome will have congenital heart disease, and indeed the atrioventricular septal defects are the most common defects that we'll see. Let's turn our attention now to sinus venosus atrial septal defect. In this pathology image, we're looking at the heart from the right side. Right atrium on the left side of the panel, right ventricle on the right side of the panel. The blue arrow demonstrates the region of the fossa-ovalis membrane, where the secundum atrial septal defect would be located. The asterisk demonstrates the location of the sinus venosus atrial septal defect. And indeed, we'd look for anomalous pulmonary veins, which are not well demonstrated on this pathology image. In real time, we can see here in this 55-year-old female who has a sinus venosus atrial septal defect and is imaged by transesophageal echocardiography. At 0 degrees, the probe is pulled up quite high, and the arrow in the left panel demonstrates the defect, the sinus venosus atrial septal defect. And let's look at this in real time. And here we can see the defect as it comes in and out of view in the two-dimensional transesophageal imaging, and with color flow, of course, demonstrate the shunt across that sinus venosus atrial septal defect. Now, these patients will have associated anomalous pulmonary venous connection over 90% of the time. So during the transesophageal echo, it's very important to look for the associated anomalous pulmonary venous connection. And we do that by just pulling the probe up just a little bit higher, still at 0 degrees. And now the first structure that we see on the 2D image is the right pulmonary artery. We see the aorta as a circle, and the superior vena cava, which should be a circle, looks like a teardrop. That's where the arrow is located. And that teardrop malformation is present because a pulmonary vein inserts into the superior vena cava at this level. So right upper pulmonary vein inserts into the superior vena cava. Let's look at this in real time, and we can see how beautifully that pulmonary vein connects to the superior vena cava, as demonstrated both by two-dimensional and color flow imaging. So sinus venosus defect, almost always associated with one or more anomalous right-sided pulmonary veins. The left-sided veins are almost always normal in this disorder. Now, the least common type of atrial septal defect is the coronary sinus atrial septal defect, also known as the unroofed coronary sinus. Here we have two pathology images. The left panel is viewed from the right side of the heart, and the right panel is viewed from the left side of the heart. And the asterisk demonstrates the atrial septal defect in both images. So large coronary sinus with a communication between the left atrium and the coronary sinus. These can be quite difficult to diagnose by echocardiography. They're often an isolated abnormality, but they may be associated with complex congenital heart lesions or a left-sided superior vena cava. And let's look at a real-time example. This young man presented with right heart enlargement. The asterisk demonstrates the location of the dilated coronary sinus in both views. And as we look at these images in real time, we can see that the separation between the left atrium and the coronary sinus appears incomplete. And indeed, with color flow examination and contrast injection into the left upper extremity, prompt filling of the left atrium was noted. So there's a left to right shunt at the level of the coronary sinus. The left atrial pressure is higher than the coronary sinus pressure, and so a shunt occurs at that level, and right heart enlargement occurs. Again, these abnormalities are tricky to identify by transthoracic imaging. A high index of suspicion is required. Let's turn our attention now to the right ventricle. We're going to identify the characteristic features of the right ventricle. In this pathology image, we can see that the right ventricle demonstrates coarse trabeculation. There's a septoparietal muscle bundle which separates the inflow portion of the right ventricle from the outflow portion of the right ventricle. And then the tricuspid valve is unique in that it has chordal insertion directly into the wall of the right ventricle. So again, characteristic features, coarse trabeculation, and chordal insertion into the wall of the right ventricle. Contrast that with the left ventricle, as demonstrated here, less trabeculated, a smooth septal surface. It's guarded by the mitral valve, and the mitral valve is characterized by chordal insertion into papillary muscles. We'll also note that the atrioventricular valves can be identified with regard to their location on the septum, and we'll look at that just shortly. When looking at the ventricles, of course, ventricular septal defects are important things to identify when evaluating a patient with congenital heart disease. By far the most common type of ventricular septal defect is the membranous ventricular septal defect, and is demonstrated in this schematic as number 2. In the schematic, we're looking at the heart from the left side, so left atrium on the right and left ventricle on the left side of the screen. So number 2 is the location of the membranous ventricular septal defect, and that makes up about 80% of ventricular septal defects. The next most common in Caucasians is the muscular defect, accounting for about 10% of ventricular septal defects. More common in infants, but due to spontaneous closure, we see these defects less frequently in adults. The outlet ventricular septal defect, as characterized by the number 1, occurs in about 6% of Caucasians, but is as common as 1 in 3 ventricular septal defects in the Asian population. And we'll look at some other and additional images with regard to this. And then finally, the inlet ventricular septal defect is the least common. It's depicted by number 4 here and occurs in less than 5% of ventricular septal defects identified. Let's look at each of these in more detail. This heart is looked at from the left side, and the asterisk demonstrates a large muscular ventricular septal defect. It's remote from atrioventricular valves, but because of its size, caused severe pulmonary hypertension. In these real-time images, long axis view on the left, short axis view on the right, we can see shunt through the mid portion of the muscular ventricular septum. So a muscular ventricular septal defect demonstrated in 2 views in this patient. We'll be looking in this patient for evidence of left heart enlargement and pulmonary hypertension to determine whether intervention is required. Muscular defects, of course, can occur anywhere on the septum. You'll hear more about that. This is an apical muscular ventricular septal defect, and spontaneous closure, as I've mentioned, can occur quite frequently. If they're small, they should be observed. If they're large, they should be closed early in life. and we'll hear more about indications for intervention later in this series. As mentioned, the membranous ventricular septal defect is the most common. This image from the left heart demonstrates its close proximity to the aortic valve, and it's not surprising that aortic valve disease can occur in conjunction with these defects. So we need to look for aortic valve problems. In addition, the tricuspid valve on the other side is also in close proximity, so tricuspid regurgitation can occur as the tricuspid valve plasters against that ventricular septal defect to try to close it. The management, again, depends on the size of the defect and associated features. And of course, all of these defects are prone to the potential for endocarditis. Let's look now at the echocardiographic images that we might see in a patient with a membranous ventricular septal defect. Two-dimensional image on the left side, color flow on the right side. The blue arrow demonstrates the location of the membranous ventricular septal defect, and this is located in close proximity to the tricuspid valve on this short axis view. But also, if you look at the aortic valve as the face of a clock, it's in the 10 o'clock position. And with real-time imaging, that shunt is clearly visible. It occurs primarily during systole. Occasionally, a little bit of flow persists in diastole. And again, in close proximity to the tricuspid valve, and in the 10 o'clock position if the aortic valve is viewed as the face of a clock. The outlet ventricular septal defect, also known as infundibular, supracrystal, or doubly committed, is located in a different position. In this pathology image viewed from the left heart, the asterisk demonstrates that location. It's more anteriorly located and indeed is in very close proximity to the aortic valve. So aortic valve regurgitation is often progressive in these patients and may be an indication for intervention. And in the echocardiographic assessment of the patient with outlet ventricular septal defect, long axis image on the left side, short axis image on the right side, and the arrow demonstrates the location of the shunt in this patient. And here we see the arrow demonstrates the location is in close proximity to the pulmonary valve or in the 2 o'clock position if the aortic valve is considered the face of a clock. And with real-time imaging, shunting can be demonstrated in the long axis view. And again, the important thing here is to locate the ventricular septum or the ventricular septal defect, which is on the apical side of the aortic valve. And in the short axis view, where is it located in this situation close to the pulmonary valve, so we know that this is an outlet ventricular septal defect. Let's turn our attention now to the cardiac connections, veno-atrial, atrioventricular, and ventriculo-arterial. We're not going to talk much about the veno-atrial connections. Again, we can see them indirectly by echocardiography, and generally these are normal, but the major ones that we want to discuss today are the atrioventricular and the ventriculo-arterial connection. The atrioventricular connection is an important echocardiographic landmark in the evaluation of patients with congenital heart disease. And this schematic demonstrates the area of interest. It's the point where the atrial septum and the ventricular septum join, and you can see that the mitral and tricuspid valves are also in play here. Anterior leaflet of the mitral valve and septal leaflet of the tricuspid valve. An important landmark because the septal tricuspid valve leaflet, as is demonstrated, is apically displaced as compared to the anterior mitral leaflet. That results in a portion of the septum, which is called the atrioventricular septum. It is located in the right atrium on the right side, but in the ventricle on the left side. So atrioventricular septum, but the offset of the valves also helps us to identify which atrioventricular valve it is and which ventricle we're considering. In this pathology image, which is cut in inflow view, we can see again a beautiful example of the offset and apical displacement of that tricuspid valve, the septal tricuspid valve, on the left side of the panel, and the higher insertion of the mitral valve, the anterior mitral leaflet, on the right side of the panel. So again, the cardiac crux is the meeting point between the atrial and ventricular septa and the septal portion of the mitral and tricuspid valve. So that refers to the inflow portion of both the left ventricle and the right ventricle. Let's look at a real-time image here. The arrow demonstrates the insertion of the septal tricuspid valve leaflet, and in real time we can see indeed that that's quite offset compared to the mitral valve, but still within normal limits. So this is a normal cardiac crux, apical displacement of the septal leaflet as compared to the mitral valve. And this is important because the tricuspid valve, once identified, always goes along with the right ventricle, and the mitral valve always goes along with the left ventricle. So an important echocardiographic landmark. As demonstrated here again in this image, the offset impacts valve morphology. Again, tricuspid valve is apically displaced, and so we know that the tricuspid valve is associated with the right ventricle, and that the mitral valve, the superiorly inserted AV valve, is associated with the left ventricle. So important for valve and ventricular morphology. Let's look at some abnormalities then of the cardiac crux. The first is inversion of the cardiac crux. And in this pathologic image, the asterisk demonstrates the left atrium, and the arrow demonstrates the offset of the atrioventricular valve. So we know that that's a tricuspid valve, and that is in conjunction with a morphologic right ventricle. So atrioventricular discordance is present in this anatomic specimen. So discordant atrioventricular connection. Remember, of course, the concordant atrioventricular connection is the normal anatomy. Right atrium is connected to right ventricle and left atrium to left ventricle. Remember when we talked about looping, that this is actually an example of an L loop, because the morphologic right ventricle and its tricuspid valve lie to the left of the morphologic left ventricle. So L loop or L transposition, also known as congenitally corrected transposition. And as we look at a real-time image, this still image nicely demonstrates, again, the arrow demonstrates the offset of the apically inserted tricuspid valve as compared to the mitral valve, which is in this situation on the other side. So we can also see pulmonary veins connecting to that atrium, which connects to the tricuspid valve. So this is atrioventricular discordance. And in real time, we can also appreciate that that ventricle, the systemic ventricle, is very trabeculated and appears abnormal. It doesn't look like a normal ventricle. So atrioventricular discordance in this patient with congenitally corrected transposition. And the problems that arise in these patients you'll hear more about later, but not surprising, the morphologic right ventricle doesn't stand up to the systemic circulation, neither does the tricuspid valve, so we see ventricular dysfunction and atrioventricular valve regurgitation. So systemic atrioventricular valve regurgitation. And here's just another nice example, echo example, apex down format. Left atrium on the right side of the screen that connects to an apically inserted AV valve and a trabeculated ventricle. So we know that a left atrium connects via the tricuspid valve to the right ventricle. And of course, we need to look at the great vessels, but we know that this is a good example of atrioventricular discordance. The crux can also be displaced, as is demonstrated in Ebstein's anomaly. That's a perfect example of that. The pathology image on the left panel demonstrates the characteristic features. Apex down format. The arrow demonstrates the excessive apical displacement of the septal tricuspid leaflet. There's elongation and tethering of the anterior leaflet, making an area that's called the atrialized right ventricle, which is demonstrated here with an asterisk. And because the tricuspid valve is so abnormal, it's often regurgitant, causing right heart enlargement. The left heart is also abnormal in individuals with Ebstein's anomaly. Not only is it compressed, but the morphology and function of the left ventricle is often also abnormal. And as we look at the real-time image in the right panel, we can see a nice example that correlates to that pathology image. very small left heart chambers that are on the right side of the screen, and then the right heart chambers on the left side of the screen, very large, extremely large. There's apical displacement of the septal leaflet, elongation and tethering of the anterior leaflet, and there was associated severe tricuspid valve regurgitation. And again, you'll see additional images later in this series. Now, deficiency of the atrioventricular septum can also occur, and the characteristic example of this is the common atrioventricular septal defect. Here in this pathology image, we're looking at the heart from the right side. Right ventricle on the right side of the screen, right atrium on the left side of the screen, and the asterisk demonstrates a large common atrioventricular septal defect. So both ASD and VSD together in this abnormality. And an echo image of this, nicely demonstrated, again, apex down format. Left heart chambers on the right side, right heart chambers on the left side of the screen. And you can see a large communication between the atria and the ventricles, and indeed this is a common atrioventricular valve, something that we can't say for sure from this image, but that was the case. Now, this is the most extreme form of atrioventricular septal defect. We saw a primum atrial septal defect earlier, and this is the most extreme form of the atrioventricular septal defect. Finally, when we talk about the atrioventricular connections, they can get more complicated, and here we see very abnormal atrioventricular connections, such as the double inlet, the single inlet in the middle, and the common inlet on the right panel. And let's just look at a real-time example. Again, in this image, the pathology image demonstrated in apex down format. The left atrium is on the right side of that pathology image. The right atrium is on the left upper panel. But there are two atrioventricular valves that connect to one ventricle. We can't see the second ventricle, but it's almost always there, but very small. In the real-time image, you can see an example of an adult who has this type of double inlet left ventricle. And indeed, this patient had had a prior palliated Fontan procedure, which you can partially see in this image as well. So double inlet left ventricle or univentricular atrioventricular connection. And finally, the ventriculo-arterial connections are important. This is a beautiful example of a patient with detransposition of the great vessels. So the right ventricle is in the correct position, but there's ventriculo-arterial discordance. So the aorta you can see coming off that right ventricle. The right ventricle is demonstrated by the asterisks. So ventriculo-arterial discordance. So remember, the concordant ventriculo-arterial connection is right ventricle giving rise to the pulmonary artery and left ventricle to the aorta. In the discordant ventriculo-arterial connection, the right ventricle gives rise to the aorta, and the left ventricle gives rise to the pulmonary artery. Again, from the looping standpoint, this is a D loop because the morphologic right ventricle with its tricuspid valve is to the right of the left ventricle. And these schematics just demonstrate, again, the concordant ventriculo-arterial connection, which is the normal orientation, and the two types of discordant ventriculo-arterial connection that we can see. In patients with detransposition, as demonstrated in the middle panel, the aorta comes off the right ventricle and the pulmonary artery off the left ventricle. So that is abnormal, and these patients can't survive long unless they have an intervention. Conversely, in the discordant ventriculo-arterial connection, as we saw with L transposition or congenitally corrected transposition, in this situation, the aorta comes off the right ventricle, but remember, that's also the atrium that comes from, receives pulmonary venous blood. So the blood goes through the wrong ventricle, but goes in the correct direction. In the past, this was known as double discordance. So atrioventricular and ventriculo-arterial discordance or double discordance. Just a few comments about the postoperative population. You'll hear much more about this later in the series. Important from the adult congenital heart disease standpoint because this is an increasing population. When imaging these patients and indeed seeing them in the clinic, we really need to confirm that we know exactly what the patients had done and get the operative reports whenever possible. And then it's also critically important to know the residua that one would expect to see with particular lesions. So let's look at just a couple. Coarctation of the aorta is demonstrated here by a CTA. Critical coarctation and a big collateral vessel are demonstrated. What are the residua even after successful repair? Hypertension is present in up to 75% of patients, and this can cause systolic and diastolic dysfunction. Recoarctation is not uncommon, and indeed aneurysms can form in the region of prior coarctation repair. These patients are also prone to aneurysm formation in the region of the ascending aorta, and of course aneurysms in either location are at increased risk for aortic dissection. Over 50% of patients with coarctation will have a bicuspid aortic valve, and so we look for complications related to that: aortic stenosis, aortic regurgitation, and endocarditis. Mitral valve disease, relatively uncommon, but can occur in patients with coarctation. Of course, these patients are at increased risk for endocarditis or endarteritis. And then in the long-term follow-up of patients with repaired coarctation, one of the highest likelihoods of problems and causes of death are actually acquired disorders, coronary disease and heart failure. So we need to be on the lookout for those disorders as well. And finally, our group has demonstrated that there's a 5-fold increased risk of brain aneurysms in patients with coarctation. And so we need to be on the lookout for that and screen patients periodically. And indeed, these patients are at increased risk for stroke, whether they're just from the brain aneurysms or also from other disorders, is certainly a concern. Tetralogy of Fallot, the most common cyanotic congenital heart defect. You'll hear a lot more about that in the series. But remember that the repaired patient is not cured of congenital heart disease. And indeed, the most common problem that occurs in these patients is pulmonary valve regurgitation. The schematic, which is demonstrated on this slide, demonstrates the heart from the right side. We're looking at right atrium and right ventricle, and you can see there's a patch across the right ventricular outflow tract. And indeed, this patch sacrifices function of the pulmonary valve. And so pulmonary valve regurgitation occurs very frequently in these patients. And you can see the pulmonary valve regurgitation occurring in this patient and ultimately will result in right heart enlargement and progressive tricuspid regurgitation. Other complications involving the right ventricular outflow tract can also occur. These patients are at increased risk for arrhythmias, and indeed that's a common cause of late death, sudden cardiac death, and careful evaluation is critically important. A residual or recurrent ventricular septal defect may be seen. As I mentioned, dilatation of the annulus can cause progressive tricuspid valve regurgitation, and indeed these patients can present with severe right heart dysfunction and or left heart dysfunction as well. Complications can occur as a result of prior shunt placement. In the current era, patients are repaired directly, but many years ago, they would have shunt procedures to improve pulmonary blood flow as a staged procedure to full repair. And so we can see complications related to these shunt procedures, and you'll hear more about those shunts later in the series. The aorta tends to enlarge in these patients, and aortic valve regurgitation as well as aortic aneurysm formation can occur. And then, of course, just like any other patient with congenital heart disease, endocarditis is a potential concern. And the last lesion I'm going to talk about is detransposition of the great vessels. We saw the nice pathology image, and it's important to know that adults with detransposition will commonly present to your practice. The common types of repair for these individuals done in the early days. Initially, the first operation that was performed was the Senning procedure, and that was pioneered by a surgeon, Dr. Senning, and initially described and performed in 1959. Next on the scene was the Mustard operation, performed again by a surgeon named Dr. Mustard, and that was initially performed in 1964. And these are termed the atrial switch operations, and we'll look at an example in just a minute. If a patient with detransposition has a ventricular septal defect, then the operation that they'll often have had done is a Rastelli procedure, named after Dr. Rastelli, the surgeon. And in this situation, the ventricular septal defect is closed so as to redirect left ventricular blood to the aorta, and then the conduit is placed from the right ventricle to the pulmonary artery. So patients may present with this, and we can see specific problems, which we'll outline just shortly. And finally, in 1975, the arterial switch operation was initially described. So now we are seeing adults who have had the arterial switch operation as a procedure to correct detransposition of the great vessels. So again, this is a schematic demonstrating the mustard operation, but the setting is very similar. And in this operation, systemic venous blood, as demonstrated here, SVC and IVC, is redirected across the mitral valve and into the left ventricle, because remember, the left ventricle is connected to the pulmonary artery. And pulmonary venous blood, as demonstrated by LU, or left upper pulmonary vein, and RU, or right upper pulmonary vein, is redirected across the tricuspid valve and into the right ventricle, which of course in this situation is connected to the aorta. So this operation, the atrial switch operation, redirects the venous blood to the other ventricle and then leaves the morphologic right ventricle as the systemic ventricle. These are two images from a patient with detransposition after a mustard procedure. The left panel is an apex down format, and the right panel is a long axis format. The asterisk demonstrates the systemic right ventricle. So remember, this is the ventricle that's pumping to the body. So as we look at this image, again, in a patient who had repair of detransposition many years ago, we can see that that ventricle is very hypertrophied because, of course, it's the systemic ventricle. So we'd want to look at ventricular function and atrioventricular valve function, and then also carefully look at the baffle anatomy. Now, I've added the long axis view here because remember that the left ventricle connects to the pulmonary artery, and so one of the tip-offs to the diagnosis, other than the apical image, is that that pulmonary artery dips posteriorly and then bifurcates right away. So that's the other thing that will tip you off to the diagnosis if the patient doesn't know what procedure they've had done. You'll hear more about these disorders, but the common complications that we see after mustard or Senning procedure are atrial arrhythmias because of the complicated surgery that's been done in the atria, baffle obstruction or baffle leak, and a leak is like an atrial septal defect, right heart failure, and this pathology image demonstrates the massive enlargement and hypertrophy which has occurred in the systemic right ventricle, which is demonstrated by the asterisk. And actually that's compressed the left ventricle, which of course was pumping to the lungs, the right ventricle pumping to the body. And then tricuspid regurgitation, because again, the tricuspid valve is in the systemic circulation. The Rastelli we discussed, again, an operation performed for detransposition in a patient with an associated ventricular septal defect. So the ventricular septal defect is closed so as to redirect the blood from the left ventricle to the aorta, and then a conduit is placed from the right ventricle to the pulmonary artery. And this pathology image demonstrates that large conduit that runs across the anterior surface of the heart. Complications that are common are left ventricular outflow tract obstruction, conduit obstruction, and many times these patients have had multiple operations to replace the conduit, recurrent ventricular septal defect, aortic enlargement, and aortic valve regurgitation. And finally, we mentioned that the arterial switch procedure has been performed since 1975. And so we are seeing adults with congenital heart disease who have had this procedure performed. In this operation, the two great vessels are transected and then interposed, and indeed the coronary arteries need to be repositioned. So not unexpectedly, the problems that we'll see after this procedure include problems with the coronary anastomosis, problems with the anastomosis of the great vessels, narrowing in particular, and then problems with the semilunar valves, because the pulmonary valve, the patient was born with a pulmonary valve, is now sitting in the systemic circulation. In summary, echocardiography remains the primary imaging tool for most patients with congenital heart disease. And it is imperative to remember that the systematic approach provides clear assessment of even the most complex patient in most circumstances. Thank you.
Today I'd like to discuss with you shunt lesions and the echocardiographic evaluation of these defects. I'd like to begin with the atrial septal defect. The atrial septal defect is the second most common congenital defect recognized for the first time in adulthood. The reason for this late recognition is that the symptoms are often progressive in these patients and the physical exam findings can be quite subtle. Atrial septal defect anatomy is complicated both embryologically and echocardiographically. The atrial septum has multiple communications and connections made embryologically, and at each one of these connections there can be a defect occur. That leads to 4 types of defect: the secundum defect, the primum defect, the sinus venosus defect, and the unroofed coronary sinus. Echocardiographic evaluation of atrial septal defects is really the gold standard because it can give us the location and type of the defect, the hemodynamic sequelae, which is indicated by right ventricular enlargement, and certainly we can see further sequelae by evaluating right ventricular function. Estimation of pulmonary artery pressure is helpful and indicated in these patients. And then secondary defects such as tricuspid regurgitation from annular dilatation can be evaluated. In any type of congenital defect, there may be more than one defect present, and echo is an excellent tool to help us identify other lesions. We can then determine repair options of any type of atrial septal defect after looking at the echocardiographic evaluation. The diagnosis of atrial septal defect is quite good, dependent on the size of the ASD. On transthoracic echo, we are quite good at evaluating and detecting large secundum defects. If they're greater than 10 millimeters, we really should be able to identify all of these defects. The small defects less than 5 millimeters are much harder to detect with transthoracic imaging, and we may miss up to 2/3 of those. However, with transesophageal echo imaging, we should determine and detect all of these types of defects. The primum defect, because of its unique architecture, is easily identified by both transthoracic and transesophageal echo and should not be missed. The sinus venosus defect, however, can be quite difficult to determine by transthoracic echo, and we may miss upwards of 90% of these defects. If there is suspicion of a defect in this area, transesophageal echo is the gold standard, and we should be able to identify 100% of sinus venosus defects with transesophageal echo imaging. Understanding the pathology of the atrial septal defect can help our echocardiographic evaluation. As we see in the upper left-hand corner, this demonstrates right atrial and right ventricular enlargement with a defect in the atrial septum in the center of the septum, with the borders completely surrounded by atrial septal tissue. The pathology correlation from the right ventricular aspect demonstrates this nicely with a large defect in the center of the atrial septum, and we can see that the rims of the defect are all atrial septal tissue. This is in distinction to the upper left corner, which is the primum atrial septal defect. We see again right atrial and right ventricular enlargement with a 2-dimensional defect at the crux of the heart. However, we note that there is a border of the atrial septal defect that is not atrial tissue but appears to be the AV valves. And the path specimen nicely correlates to this. We see a defect straddling the tricuspid valve in this picture. The lower right-hand corner demonstrates the sinus venosus type of atrial septal defect at the superior vena cava entrance. Again, right atrial and right ventricular enlargement, but the defect is back towards the superior vena cava, and we see 2 additional findings, which is anomalous pulmonary venous return to the right atrium. The unroofed coronary sinus defect is best demonstrated by a large coronary sinus, as seen in this pathologic specimen. Secundum ASD is by far the most common type of atrial septal defect, comprising at least 3/4 of all forms of atrial septal defect. The degree of left to right shunt associated with these defects are related to the diastolic or the filling pressures of the left ventricle versus the right ventricle. This is quite important to remember. As the population ages, the left ventricular diastolic pressure can increase and increase our left to right shunt without any increase in the size of the atrial septal defect itself. This left to right shunt is associated with volume loading of the right heart chambers and subsequent right atrial and right ventricular dilatation. With long-standing right ventricular dilatation, we can begin to see right ventricular systolic dysfunction, and these are important sequelae to evaluate with echo. To begin our evaluation with echo, we need to understand where to look for these atrial septal defects. We can see the secundum defect from many different echocardiographic planes. Initially, the subcostal plane can be used. Often this plane is suboptimal in adults, but if it is a good plane, we see the defect right in the center of the septum, surrounded by atrial tissue. Anytime we see the defect with two-dimensional echocardiography, we want to confirm that there is a shunt with color flow, as shown in the subsequent panel. The apical views can be used, but apical four-chamber views should not be performed where the atrial septum is completely parallel to the echo beam. So we need to tilt the apex of the we need to tilt the apex of the ventricle so that the atrial septum is at an angle to the echo beam, as shown in this slide. Then we can see often a large defect between the left atrium and the right atrium. Again, parasternal short axis imaging can show the same defect as shown here. Transesophageal echo is the gold standard. We do see the defect in the atrial septum, and color flow confirms. Let's now look at these slides and moving echocardiogram pictures. This is the same patient that we saw in still shot. This is a young woman with a large secundum atrial septal defect. This is parasternal short axis imaging, and we recognize that there is tissue defect between the left atrium and the right atrium, as seen here. We also notice that the right atrium and right ventricle appear to be enlarged. Color Doppler imaging shows that there is a left to right shunt through the area of 2D defect demonstrated previously. Scanning further down in the parasternal short axis view, we see short axis left ventricle with the right ventricle on top of the left ventricle. This shows significant right ventricular enlargement from the left to right shunt. Apical four-chamber imaging with the congenital format apex down and right-handed structures on the right of the screen shows significant right atrial and right ventricular enlargement with a septal defect demonstrated as tissue loss in the atrial septum. Color flow imaging confirms that there is a left to right shunt, and this is not just dropout in the echo plane. Primum atrial septal defect is less common than secundum atrial septal defect, but still comprises about 10% of all forms of atrial septal defect. It is associated with valvular lesions of the mitral and tricuspid valve, most commonly the cleft mitral valve, but can be associated with a double orifice mitral valve. We often note too that the tricuspid valve is abnormal in these patients, and they can have significant tricuspid valve regurgitation. The hallmark of this defect is that the AV valves, the mitral and the tricuspid valve, are at the same level. There is no offset of the tricuspid valve towards the apex of the heart. This defect is in the spectrum of the AV canal defects and sometimes is referred to as a partial AV canal. To review the anatomy here with a specimen from the Path Lab, we do see that there is enlargement of the right atrial and right ventricular chambers from the shunt. We see the loss of tissue at the lower portion of the atrial septum, and we see that the AV valves, the mitral valve and the tricuspid valve, are draped across the ventricular septum, originating at the same level. Echocardiogram demonstrates this anatomy very nicely in the upper left panel. Color flow imaging shows the left to right shunt, and color flow imaging in systole shows both mitral and tricuspid valve regurgitation, all hallmarks of the primum atrial septal defect. Again, with echo, we can see in the apical four-chamber view the mitral and tricuspid valve right at the same level with right atrial and right ventricular enlargement. The cleft valve is shown, mitral valve is shown in the lower panels. We see that the anterior leaflet of the mitral valve has a defect in its structure, and through that defect is where the mitral regurgitation originates. In a moving echo clip, we see this same patient, apical 4-chamber view, apex down. The right atrium and right ventricle are quite enlarged. The AV valves are definitely at the same level with no offset of the tricuspid valve, and there is tissue loss at the crux of the heart in the atrial septum. Color flow imaging of this same patient demonstrates a broad red jet of left to right shunt with regurgitation through both the mitral and the tricuspid valves. This is a parasternal short axis image of another patient with a primoatrial septal defect. This patient, instead of a cleft mitral valve, does have a double orifice mitral valve, nicely shown here. Let's turn our attention now to sinus venosus atrial septal defects. These are more rare. Only about 5% of all atrial septal defects will be of the sinus venosus type. These can involve either the origin or the communication between the superior vena cava and the right atrium or the inferior vena cava, but most commonly involve the superior vena cava connection to the right atrium. These defects are almost always associated with partial anomalous pulmonary venous return of the right veins. These are most commonly diagnosed on transesophageal echocardiogram, but here's a nice example on transthoracic echo showing that with good subcostal pictures we can diagnose these defects in the adult. This is an adult patient who presented with pulmonary hypertension for evaluation. In this subcostal image, we see that there is significant right atrial and right ventricular enlargement with right ventricular hypertrophy. Imaging of the atrium, again from the subcostal view, demonstrates that there is a defect as the superior vena cava at the top of the screen enters the right atrium. We don't see much shunt across the septal defect because the right atrial and right and left atrial pressures are near equal. This is a modified view to again show that there is not significant amount of right to left or left to right shunt in this patient with pulmonary hypertension. But transesophageal echo imaging is really the gold standard. This is a transesophageal echo image of another patient with sinus venosus defect. This is the bicaval view with left atrium at the top of the screen, right atrium near the bottom. We see where the superior vena cava enters the atrium that there is a large tissue defect, and the superior vena cava seems to straddle both the left and the right atrium, providing essentially a left to right shunt. The most rare type of atrial septal defect, however, is the coronary sinus defect. This is also called an unroofed coronary sinus, and it can result in significant right atrial and right ventricular enlargement related to shunt across the unroofing of the coronary sinus, as the left atrial pressure is usually higher than the coronary sinus pressure. This is thought to be associated with persistence of the left superior vena cava, but that is not always present in this defect. The echocardiographic diagnosis should be entertained when we see a large coronary sinus, especially if the coronary sinus appears to be broken instead of a complete ring. So as you look at the parasternal long axis view here, the back wall of the left atrium is usually where we see a small circular structure that is the coronary sinus. Here we see the coronary sinus is definitely enlarged in the left atrium, and the roof is certainly not complete. It appears to be a tissue defect here. Zooming up on that view, we see again the large coronary sinus with evidence of a shunt moving from the left atrium into the coronary sinus. So this is a true coronary sinus form of atrial septal defect. The large coronary sinus and its unroofed portion can be seen in an off-axis parasternal short-axis view as shown here. Because of the persistence in many of these cases of a left superior vena cava, it can be advantageous in the diagnostic and evaluative efforts to give a bubble study or agitated saline contrast in a left arm injection. In this patient, we have placed an IV in the left antecubital fossa and given agitated saline. We see, however, that there is no saline entering the coronary sinus or the left atrium, but the saline simply fills the right ventricle in this view. This would be indicative that there is no persistence of the left superior vena cava. In this patient, however, we see that there is a large coronary sinus with appearance of being unroofed. With an injection in the left arm, we see bubbles initially first in the coronary sinus, then in the left atrium, and subsequently in the right ventricle. This is a patient with coronary sinus type of atrial septal defect with persistence of the left superior vena cava. Let's turn our attention now to ventricular septal defects. Ventricular septal anatomy is complicated both in three-dimensional space and embryologically. Defects of the ventricular septum can be divided into membranous type and muscular types. The membranous ventricular septum comprises a very small portion of the ventricular septal anatomy, but it actually is where most of the ventricular septal defects occur embryologically. The muscular ventricular septum can be further divided into inlet defects, true trabecular defects, and outlet defects, with the inlet defects being that muscular portion that separates the ventricular inflows, and the outlet defects being the muscular portion of the septum that separates the outflow tracts, or the aorta and the pulmonary artery. When we look in two-dimensional space at the three-dimensional aspect of the ventricular septum, we see that it is quite complicated and takes a very serpiginous path. So if we look from the base of the heart, where this orange line traverses, is everywhere where we can see ventricular septal anatomy at some plane. Of the ventricular septal defects, about 80% will involve the membranous septum, and sometimes we call these perimembranous defects if the defect also has some extension into the muscular portion around it. So you may hear the nomenclature a perimembranous defect with inlet extension or outlet extension. Muscular defects do occur, however, and again are divided into inlet, outlet, and then we should consider the post-MI defect in the adult, which by definition must be all a muscular defect. The outlet defect goes by multiple different names, and we do see these called infundibular defects and the supracrystal or subarterial defect. All, however, are defects in the outlet muscular septum. To understand where these defects occur, it's helpful to look at this schematic drawing. From the right ventricular side, we see where the number 1 is where the membranous ventricular septal defects will be. Number 2 is outlet muscular. Number 3, true trabecular muscular. And number 4 are inlet muscular defects. These same defects are represented with the same numbers from the left ventricular aspect. So again, echo is a fantastic tool for us to evaluate ventricular septal defects. With echocardiogram, we can tell where the defect is, what type of defect, how large it is, and if there's involvement in other structures, because often these ventricular septal defects will have involvement of the valves that surround them, and so we want to be able to determine that and help determine appropriate treatment for our patients. The shunt from a ventricular septal defect is left to right, but it involves left ventricular enlargement and left atrial enlargement, not right ventricular enlargement as is commonly thought. And the reason is that the left ventricle must fill with the volume that's going to go across the shunt, as well as the appropriate volume to go out the aorta. That is a volume load to the left atrium and the left ventricle. The right ventricle is in systole at the same time the left ventricle is in systole essentially, and that is when most of the volume goes across the septum. So the right ventricle really is not volume loaded but pressure loaded. The pulmonary artery sees both the volume of the defect and the pressure transmission across the defect. This is what leads to the left ventricular and left atrial enlargement. With ventricular septal defect of large size, it's very common to get irreversible pulmonary vascular disease. So it's important by echo that we estimate right ventricular systolic pressure, especially in our adult patients. This is much more common than atrial septal defect to cause pulmonary hypertension. Of course, we want to look for associated anomalies such as other congenital defects. By echocardiogram, we need to know where to look for these defects to appropriately evaluate our patients. So if we have a true parasternal long axis view, the area shown in orange is where we will see outlet muscular defects. Now this view can be tilted slightly and we will often see color flow of the membranous defect, but in a true parasternal long axis, that's actually the outlet septum. The yellow is the true trabecular septum. Parasternal short axis imaging can be the most helpful in determining the difference between a membranous ventricular septal defect and an outlet ventricular septal defect. If we are scanning at the base of the heart where we can see the LVOT or the aortic valve, and we consider the LVOT to be a clock face, 2D defects or color flow seen between 9 and noon will be consistent with membranous ventricular septal defect. Those defects demonstrated between noon and 3 p.m. would be most consistent with an outlet muscular defect. As we scan towards the apex of the ventricle, we do capture inlet muscular ventricular septum and trabecular septum at the level of the mitral valve. As we scan further apically at the level of the papillary muscles, we see all trabecular muscular septum. Apical four-chamber views can certainly be helpful. In a true apical 4 that is tilted posteriorly where we see the inlets or the tricuspid and the mitral valve, that's where we're going to see the inlet muscular septum as well as the trabecular septum as demonstrated here. The membranous defect can be seen if you turn into a 5-chamber view where the aortic outflow is demonstrated. So let's look at some of these examples with echocardiograms. In this patient, we see a parasternal long axis view. We note here before even turning on the color flow that there seems to be some cusp prolapse across the ventricular septum, and so that's our first sign that there may be a defect here. Color flow imaging demonstrates definite color flow between the left ventricle and the right ventricle, and this is an outlet type of ventricular septal defect. Parasternal short axis imaging of the same patient is helpful. It does show color flow towards the pulmonary valve. So this again is not a membranous defect, but is an outlet type of muscular septal defect. Now when we're evaluating these outlet defects, I want you to be aware that this can be a little bit confusing. Here we see pulmonary valve regurgitation, which is red flow in a similar plane where we can see ventricular septal defect flow. But the key here is that this flow is all in diastole, none in systole, and we see no color flow in the LVOT. So here, in distinction, is a supracrystal VSD. You can see that on just quick looking at this, that looks somewhat similar to pulmonary valve regurgitation, except that the shunt is occurring in systole, and we definitely see color flow in the LVOT. Now, how about the perimembranous defect or the membranous septal defect? This is the most common type of ventricular septal defect, where again at parasternal short axis imaging at the base, we see the aortic valve in plane, and we're anticipating color flow towards the tricuspid valve in this plane. Color flow imaging does show us that with a small shunt between the left ventricle and the right ventricle in the membranous septum. Trabecular or muscular defects, most common in childhood. If they're large, we often don't see these defects by any means in the adult. This patient with parasternal long axis imaging nicely demonstrates several defects by 2D in the trabecular septum, and color flow confirms that there are multiple defects. The post-MI VSD again will be a muscular defect, and it will occur usually at the junction between normal myocardium and infarcted myocardium. So in this patient, this is a apical 4-chamber, actually rotated into an apical 5-chamber view, we see the apex is upward in a typical Mayo adult format for echocardiogram presentation. By 2D, not convinced that there's any type of defect, but we do see that there is a regional wall motion abnormality of the septum, but good function near the apex. Zooming up at the apex and turning on color flow demonstrates that there is a shunt between the left ventricle and right ventricle in this patient, right at the junction between the infarcted and normal myocardium. The inlet type of ventricular septal defect is also in the spectrum of the AV canal defect, and we see it best in the apical 4-chamber view tilted posteriorly, where we see just the mitral and tricuspid inflows to the ventricles. Here we see by 2D a large defect in this area. And with color flow imaging, we see a shunt that actually is not very impressive because of the size of the defect is significant, and there is pressure loading of the right ventricle. A true AV canal defect will have both a primum atrial septal defect and a ventricular septal defect in the inlet septum, so the whole crux of the heart will appear to be missing, as in this case with the apical 4-chamber view, apex down. We see right heart and left heart enlargement. In this case, we see a defect in the primum area of the atrial septum. The AV valve is essentially a single valve instead of a separate mitral and tricuspid valve. And then we see a defect in the ventricular septum. So the ventricular septal defect can be evaluated in terms of size by either looking at the diameter of the defect or comparing it to the aortic root. A small defect is often called a restrictive defect because it restricts pressure transmission from the left ventricle to the right ventricle. These defects are small, less than 1/3 of the aortic root diameter, and the velocity across them is usually quite high, usually greater than 4 meters per second. Moderate defects are about half the size of the aortic root, and the velocity is lower, around 3 meters per second. Large ventricular septal defects allow no restriction of pressure between the left and the right ventricle. So these are called non-restrictive defects. And so the right ventricular pressure is often equal to the left ventricular pressure, and there is essentially no shunt or a very low velocity shunt. So remember, when you're evaluating a ventricular septal defect by echo, that the ventricular septal defect jet could contaminate your tricuspid regurgitation signal. It's very important for us to capture an accurate tricuspid regurgitation signal to evaluate the right ventricular systolic pressure. But as you can see from the previous slides, if you had a membranous small ventricular septal defect, that high velocity jet, maybe 4 or 5 meters per second, is pointed towards the tricuspid valve, and that velocity could be entrained in your continuous wave Doppler signal. So be cautious with what looks to be a small defect if you think that you have a high estimated right ventricular systolic pressure from a high velocity TR signal. The caveat is also true with a very large defect that has caused significant right heart pressure increase. You may not see much color flow at all, and you may not be able to turn on color and confirm to yourself that you have a defect. You just see the two-dimensional dropout in tissue. In any patient, whether it's a ventricular septal defect patient, atrial septal defect, or other concern, we need to be very cautious before on echo we describe the patient as having pulmonary hypertension. Remember, we're looking at the tricuspid valve regurgitation velocity, and the tricuspid valve regurgitation velocity through the Bernoulli equation only estimates RV pressure. We assume that RV pressure is pulmonary artery pressure if there is no type of outflow tract obstruction. So anytime we have a high tricuspid valve regurgitation velocity, we need to consider whether or not there is some outflow obstruction into the pulmonary artery, including valvular or subvalvular pulmonary stenosis, or with certain types of ventricular septal defect, an entity called a double-chambered RV, where there's heavy muscle bundles in the mid-ventricle of the right heart that can cause obstruction and cause a high-pressured proximal chamber to the tricuspid valve, but a low-pressure distal chamber. We also need to remember that with a small VSD, we might have contamination of our tricuspid regurgitation velocity, and we may not be able to estimate RV pressure based on TR. If that is the case, we want to try to look at other measures of pulmonary hypertension, such as the pulmonary end diastolic regurgitation velocity to estimate PA diastolic pressure. If we do think that our TR velocity is elevated and estimates true pulmonary artery pressure, we do need to recall that there are other reasons to have high main pulmonary artery pressures without significant intrinsic vascular disease. And one thing in congenital heart disease that we do often see is branch PS. Now usually we need bilateral or significant branch PS to cause elevation of the main pulmonary artery pressure, but that's something that we should consider, and we can see the proximal branch PAs with echo and can Doppler those, so that should be performed. Now we may truly have pulmonary vascular disease, and that's really what we want to understand if we're anticipating whether or not we can close a septal defect. Pulmonary vein stenosis can be a cause of pulmonary hypertension, so especially in the patient who has had any type of ablative procedure or intervention that could have led to pulmonary vein stenosis, we need to consider this entity as well. And then the older patient with atrial septal defects who we're evaluating, we need to remember that they may have left atrial hypertension from restrictive LV hemodynamics that could be driving both their shunt and the appearance of elevated pulmonary artery pressures. Finally, when we're thinking about pulmonary artery pressures, we need to remember that pulmonary artery pressures are related to the flow, or QP, through the pulmonary bed as times the pulmonary vascular resistance. We're really concerned if the pulmonary vascular resistance is high, but you can see with a significant shunt with high QP, you can have high pulmonary artery pressures with a low or near normal pulmonary vascular resistance. So in any patient with a septal defect that you're evaluating that has appearance of elevated pulmonary artery pressures, they need to go to the cath lab for true evaluation of their pulmonary vascular resistance. There are formulas to do this on echo, but they are quite complicated, and currently cath is the gold standard. Well, complications of ventricular septal defect are significant and unfortunately quite prevalent. Large ventricular septal defects will result in irreversible pulmonary vascular disease, usually in childhood. This is called the Eisenmenger syndrome. Small ventricular septal defects with their high velocity jet lesion can result in endocarditis. Aortic valve regurgitation is unfortunately a complication of defects that have prolapse of any of the cusp of the aortic valve into the defect itself. The infundibular type of outlet ventricular septal defect is associated with increasing hypertrophy of muscle bundles and can result in a double-chambered right ventricle. We can see LV dysfunction over time. Certainly atrial and ventricular arrhythmias can occur, and then tricuspid valve regurgitation if the tricuspid valve leaflets are associated or entrained into especially a membranous defect. Here's an echo example of the double chamber RV we've been discussing. This is parasternal short axis view at the base. We see the aortic valve in plane and then the body of the right ventricle. You do appreciate that there is some hypertrophy of a muscle bundle there, but the color flow is what's quite helpful. We see this high velocity or turbulent color flow across this muscle bundle. Now it can be quite hard to get your continuous wave Doppler lined up here to get a true pressure gradient, but with altering your plane you usually can get your cursor in there, and we see here that this patient has significant obstruction because of that muscle bundle with a peak velocity of almost 5 meters per second through that mid-body of the right ventricle. So when should we recommend closure of a patient that we see with ventricular septal defect? Well, if there's a large ventricular septal defect that's caused hemodynamic compromise, so that is left heart enlargement, or if you're doing this by cath, a QP/QS greater than 1.5, we want to consider closure, but you should only close those patients if they don't have evidence of irreversible pulmonary vascular disease and pulmonary hypertension. One caveat about the QPQS, again, this could be calculated with echo, but it's not recommended because it's quite difficult to get the QP component calculated appropriately, as we do need to get a diameter of the pulmonary outflow tract that's accurate, and that can be quite difficult. So if we get that diameter inaccurately measured, we will introduce significant error into the calculation. Other indications for closure, even with small ventricular septal defects, would be aortic valve prolapse with evidence of progressive regurgitation, RV outflow tract obstruction as seen with the double-chambered RV, and any episode of endocarditis related to a ventricular septal defect. Closure methods are usually surgical in nature. There has been enthusiasm about transcatheter closure, but currently there is no membranous occluder device available because of complications seen in early trials. So any patient with a membranous ventricular septal defect would need surgical closure. Now, patients with post-MI defect can have closure with a catheter approach, and sometimes that's actually beneficial instead of considering surgical options. And there are occluders, both a muscular occluder and a post-MI occluder, available for these patients. Let's turn our attention now to patent ductus arteriosus, a more rare form of a shunt lesion, but this can be certainly picked up in adulthood. Patent ductus arteriosus causes left heart enlargement similar to ventricular septal defect, and pulmonary hypertension is common if the ductus is large. Again, this can be quite difficult to pick up on echo if the defect is large, because there may not be any shunt flow demonstrated because of the equalization of pressures. Most of the time in the adult lab, we will see a small, insignificant hemodynamic patent ductus arteriosus. This is a peristernal short axis view. We're off axis to try to open up the main pulmonary artery in the branch PAs. And when we turn on color flow imaging, we see continuous flow in sort of the crux of where the branch PAs, closer to the LPA. This is different from pulmonary valve regurgitation, which is diastolic only and should be seen originating at the valve. So here is pulmonary valve regurgitation. Let's turn our attention now to partial anomalous pulmonary venous connection. This is not uncommon, but can be quite difficult to diagnose with echo alone. There's multiple variations of the anomalous pulmonary venous connection, with anomalies of the right veins most common, but may be more difficult to pick up with echo. Left pulmonary venous anomalies are rare, about 4 to 5% of forms of partial anomalous pulmonary venous connection, but these are actually quite easy to pick up with transthoracic echo, and I will demonstrate this for you. The scimitar syndrome, which is partial anomalous return of the right veins to the IVC below the diaphragm, is quite rare and is usually associated with other congenital and pulmonary defects. Connections to the coronary sinus can occur, but these are very rare. And embryologically, it's difficult to explain how partial bilateral anomalous pulmonary veins can occur, but we have seen this in echo and in the clinic. So if we look at this schematic, I find this helpful. We should have normal anatomy here with at least 4 veins returning to the left atrium. The most common variant will be a single anomalous vein to the superior vena cava, and sometimes we'll see 2 veins returning to the superior vena cava. This is the scimitar syndrome, right lower pulmonary vein to the IVC. And then this is what's called a vertical vein, where 1 or 2 left veins return to a vertical vein which connects to the innominate vein and then the SVC. This is the type of defect that we really should not miss on transthoracic echo. Quite easy to demonstrate if we're looking for it. These defects, coronary sinus return of partial veins, is quite rare, but would be seen on echo as large coronary sinus with evidence of abnormal color flow into it. So of all the types of partial anomalous pulmonary veins, they do cause a left to right shunt, and so we should expect right chamber, right atrial, and right ventricular volume overload and dilatation. These defects can result in pulmonary hypertension similar to atrial septal defects, But if you have a single anomalous vein, it's really unusual that you would get hemodynamic compromise, including even volume load of the right ventricle. If you have less than a 50% shunt, it would be rare to have symptoms in childhood. So you can see that most of these defects may be picked up in the adult population. The magnitude of the left to right shunt is quite complicated. It's related to the number of anomalous veins as well as the pulmonary segments drained by those veins, the resistance of the pulmonary bed, and then the end diastolic pressures of the ventricle. So a bit more complicated than understanding the atrial septal defect shunt. If you have a sinus venosus defect, upwards of 95% of those patients will have an anomalous vein. So certainly if we see that type of ASD, we want to be thinking about partial anomalous pulmonary venous return of the right veins to the SVC. With secundum atrial septal defect, it's much rarer, and only about 10 to 15% of those patients at most will have an anomalous pulmonary vein. Patients with mitral valve stenosis can have anomalous venous return, as well as patients with tetralogy of Fallot, but I would not say that it's the norm. And then patients with anomalous pulmonary venous return would be expected to have potentially right axis deviation, and they may have first-degree heart block. By echo, if we're evaluating a patient with partial anomalous pulmonary venous connection, we want to try to determine the type of connection. But again, this can be quite difficult as we really are limited in the view of the superior vena cava in many of our patients. If you can get a good view of the superior vena cava, you can see right veins returning with abnormal color flow into the SVC, but this is a difficult proposition. We want to look for associated anomalies such as the other types of atrial septal defects, and then evaluate the sequelae, looking at the right heart size and function, as well as evaluating the pulmonary artery pressure. This is the evaluation of the left vertical vein, where left anomalous veins return back to the innominate vein. This is a suprasternal notch view. We see the aorta here, but when we turn on color flow, we see that there's red flow, or flow towards the transducer near the descending thoracic aorta. The only time we could get red flow there would be a vertical vein. There should be really no other flow. And we do see that the innominate vein draping over the aorta is quite large, related to the shunt flow. So the treatment of partial anomalous pulmonary venous return is surgical only, and the type of surgery depends on where your anomalous veins reside. If you have a left vertical vein, as seen in the last echo clip, this is actually a relatively straightforward surgical procedure where the vertical vein is anastomosed to the left atrial appendage, and this can even be done off pump. Right veins, however, can be quite complicated, and their surgical redirection depends on the location as they return into the superior vena cava or the inferior vena cava. So in conclusion, I want you to recall, as we're evaluating atrial septal defects, ventricular septal defects, and the other shunt lesions, that right heart enlargement occurs when there's an atrial septal defect or partial anomalous pulmonary venous connection. Left heart enlargement results from a ventricular septal defect or a patent ductus arteriosus. No matter what the type of shunt lesion, if the patient has developed significant pulmonary hypertension, they may not have a lot of color flow shunt visible on echo, and the diagnosis can be more difficult to ascertain. Thank you for your attention of this presentation regarding shunt lesions in the adult patient. I hope you find this helpful in your echocardiographic practice.
I hope you have enjoyed this program and that the information will help you in your clinical practice. For more information on other programs in the Tutorials in Echocardiography series, as well as other educational series, please visit our website or email us at the information shown on the screen. Thank you for joining us.